And we're going to be talking about interprofessional approach to improving oral intake in hospitalized patients. And so I just was going to give a bit of introduction about who I am, and then Carlotta, who is my co-presenter, is also going to present herself in terms of her introduction. Just to be aware that I'm actually going to do the first part of the presentation, so not like it is in the program where it has Carlotta first. I will be doing the first part, and we actually will roll right into Carlotta's presentation, because it's really part one, part two sort of thing, and there isn't a definition in terms or a separation in terms of what we're doing. We have the very same slide deck. So I'm the Schlegel Research Chair in Nutrition Aging at the University of Waterloo, and I have the pleasure of doing research at that university around older adults and nutrition. And I'm also involved with the Canadian Malnutrition Task Force. I chair that group, who is a standing committee of the CNS, Canadian Nutrition Society, and we've been involved in doing research for the last 5 years around hospital malnutrition. I'm a dietitian by training, an epidemiologist, and a screening expert, and that's how I come into the hospital sector, not as a acute care dietitian, but as an expert in screening and nutrition risk. So Carlotta, if you can introduce yourself, and then we'll get rolling.
Thank you very much, Heather, and thank you for including me in this presentation as well. I'm Carlotta Basualdo-Hammond, the Nutrition Services Executive Director for Provincial Strategy, Standards and Practice, big title, and Alberta Health Services. And in Alberta Health Services, we have a team of managers and directors that oversee 500 or so dietitians, and my area is responsible for providing leadership for that team. And an area that we're passionate about right now is addressing hospitalized malnutrition, so I'm very pleased to be here today and share with you some of my experiences from Alberta Health Services. So thank you, Heather.
Great. And so again, just to thank CNS for having us as a symposium here at the conference, and also to thank our sponsors for sponsoring this session and bringing us together. So just a few disclosures. So I want to start off a little bit of the story of CMTF, so you understand where we're coming from and where we're going, and that leads directly, as I said, into Carlotta's presentation as examples of what's been going on in Alberta Health Services around changing nutrition care practice. So CMTF, our vision is to advance nutrition care in adult and pediatric patients through research, education, and interdisciplinary collaboration in Canada. I highlighted there advanced nutrition care because that's what this presentation is about today. I will be presenting some of the research for our NCCH study, but really we're focusing that research on the next piece, which is advancing nutrition care. And the examples that Carlotta will be going through are showing how one group has moved forward this area in their province. So a brief outline. So part one, which is me, is why do we need to advance nutrition care in Canadian hospitals? So I'll highlight a few key results from the NCCH study that was conducted between 2010 and 2013 by the CMTF. And then I'm going to show you the CMTF response, which is new. It's based on a year-long process that we just finished in March of this year. And the result is the integrated nutrition pathway for acute care. And then its subsequent study, which I'll tell you briefly about, called More to Eat. So I'm sure some of you who've seen a CMTF presentation, you'll know this slide already, but just to reaffirm what we're about here, the study, one of the biggest outcomes of the study was identifying the prevalence of malnutrition in Canadian hospitals. Before this work was done, there was only convenient samples from one-off sites or hospitals, and there wasn't a good sense across Canada, what is the prevalence of malnutrition in medical and surgical patients? And so our data demonstrates that 45% of people enter into medical or surgical units in one of 18 hospitals in 8 provinces across Canada with malnutrition. And you can see here that the majority of the group have what we call mild or moderate malnutrition, and about 12% have severe malnutrition. I also want to show you this one highlight out of the work that demonstrates what predicts a longer length of stay. So one of the key markers of acute care in terms of our care process is how long it takes someone to get out of the hospital, because you don't want them there for lots of reasons, one being cost, but also quality of life and comorbidity experience of the individual might be actually increased the longer they stay in the hospital setting, specifically thinking about frailty and function and all those sorts of things can actually be eroded as someone stays longer in the hospital. So we want to get people out of hospital as quickly as possible. So length of stay was the primary outcome variable that we used in our data collection to demonstrate how nutrition might be involved in key health care outcomes for these patients. And you see here what we call the logistic regression model that uses a hazard ratio. So I'll explain what that means for you here. A hazard ratio, anything greater than 1 means that person with that characteristic would leave the hospital sooner, so that's a good thing. A hazard ratio that's less than 1 means the person stays longer in the hospital. What's key here is that we've actually controlled for, and you see on the very bottom of that, I don't have a pointer unfortunately in this session, but in the very bottom you see we adjusted for cancer, type of unit, whether or not the level of comorbidity of the patient, so the CCI, Charleston Comorbidity Index, their education level, age, whether or not they had a dietitian visit, did they have NPO for 3 or more days, pre-admission weight loss, and BMI at admission. So all the things you think that might be linked to potentially a longer length of recovery for a patient in hospital, we controlled for. And those that are listed on this slide are those that we are considering independent predictors of that outcome. And so you'll see those that are nutrition related are highlighted in orange for you, and every one of them except for hand grip strength means a longer length of stay because the hazard ratio is less than 1, right? So you see here that people with mild to moderate malnutrition or severe malnutrition, SJB or C, more likely to stay longer in the hospital. Those who had nutrition support in the hospital, so enteroparental nutrition, also stayed longer. And those who consumed less than 50% of the food during the first week of admission also stayed longer. What's key to remember here is these are all independent predictors. This means food intake, regardless of your nutritional status walking into the hospital or not walking in to the hospital, independently predicts that recovery. So a well-nourished patient who doesn't eat their tray, basically in that first week, also stays longer. Okay, as does a person who's malnourished. The only nutrition-related variable that predicted a shorter length of stay was hand grip strength. And so a lot of us use that measure as a crude indication of nutrition. It also measures frailty. So there's something going on here in terms of if we can keep someone not being frail, better nourished, perhaps they have a shorter length of stay. All the other covariates here are also significant, and what you'd expect in terms of things like number of diagnoses and meds, indicating that the acuity of disease also lead to longer recovery for these patients. So basically, the takeaway is that nutrition and food intake are independent predictors of the length of stay of patients in Canadian hospitals. So I want to show you this slide, and this is unpublished data that's in the chart, but on the bottom, the 2 figures are published. So I'll start with those there first. About a third of patients have what we call a low food intake in their first week of admission. And how we determined this was the patient self-reported their food intake on something called the nutrition food intake form. And so it's a crude indication of the meal consumption. It's not actual individual food items. And we crudely dichotomized that as less than 50% of the tray and greater than 50% of the tray. A third of patients in that first week were not consuming 50% of the tray that's provided. And so we all know that probably the tray isn't necessarily sufficient in terms of energy and protein for a patient who's gone through surgery, for example, or is going through some additional stress of disease. And if they're not consuming half of that, they're certainly leading into a situation of increased deficits when it comes to nutrition and function. 11% were kept NPO for more than 3 days as well during this time frame. So that's a pretty high number when you think about it. So what I want to show you on this slide here is that who is eating well and not eating well. So the well-nourished, about 75% were consuming more than half their tray. So that's probably the group that we're not worried about so much. The diet-related malnutrition, so these are people that had straight SGA B or C, mild or moderately or severely malnourished without inflammation. And we use something called C-reactive protein to determine inflammatory process in these patients. They had a low CRP, which meant they had no inflammation. They also ate most of the tray. So 78% ate 50% or more of the tray. The group that doesn't eat the food based on this data collection are those who have inflammation as well as malnutrition, which is interesting when you think about the inflammatory process that's going on in the body and the acute phase reaction that we see. These people have poor appetite, might have nausea, vomiting, other sorts of things, which could lead to this poor food intake that we're seeing. And I'll show you some data around barriers to food intake, which suggests that that is the case. So if we look at this data, and I'm sorry, it's a little bit bright that you can't necessarily see the categories on the top, so I'll walk you through this. These are just bivariate associations with length of stay, with the various categories in the top chart. So on the top chart, you see that we had about 29% of people that came in malnourished, but they were stable during their admission. Then we had well-nourished that were stable, about 34% of the sample was that group. Deteriorated was about 20%. So they either started as well-nourished and moved into malnutrition, or started as mild and moderately malnourished and moved into severe malnutrition. So that's about 20% of the sample. And then a final group that improved, so they're malnourished coming in, but about 17% improved during their stay. So this is all the patients, all right? Who stayed more than 7 days. And so what I showed you here is basically some of the characteristics associated with recovery or not of nutrition. And so this is a bivariate association because you can't say anything about causality here. But it's interesting to see that a surgery patient is more likely to deteriorate, right? 49% of the surgery patients were in that group of deterioration. Okay? And we see those with more than 3 diagnoses are also more likely to deteriorate as well. There were no statistical significance in some of these other covariates that we would think important in terms of being associated with deterioration, such as the Charlson Comorbidity Index, cancer, number of medications, etc. On the bottom, again, this is just a straight bivariate association, but it shows you who's driving the length of stay. So if you remember at the very beginning, I said that the largest proportion that is malnourished are the mildly and moderately malnourished patients at about 33%. Those mildly to moderately malnourished patients who deteriorate stay 21 days on average. That's a huge length of stay. Now, that's not all of these mildly to moderately malnourished, right? It's just a portion that continues to deteriorate during their hospital stay. But that is a group that we have to be figuring out why they're not eating and try to resolve that in some shape or form. Those who are severely malnourished, you can see even when they're stable, they stay longer in hospital than a well-nourished patient, even a well-nourished patient that deteriorates, who stays on average 10 days. So if we look at what how the change in nutritional status predicts the length of stay, here we've just looked at people that stayed more than 7 days. So we did SGA at baseline, and if they stayed more than 7 days, we also did an SGA at the end of their stay in hospital. And we controlled, again, as you see on the bottom here, age, gender, number of diagnoses, the Charlson Comorbidity Index at baseline, or when they came into the hospital, as well as the change in that Charlson Comorbidity Index at discharge. So did they improve or get worse in terms of comorbidity? These 3 factors were the only things that came out to be significantly associated with a longer length of stay when they stayed more than 7 days. And again, it's a hazard ratio. So a hazard ratio that's less than 1 means they stay longer. So people coming in from residential care, like long-term care and retirement homes, for some reason are staying longer in the acute care setting. And that's independent of these other 2 factors, which are SGA that deteriorated and SGA-B that deteriorated during hospital stay. And these are the only factors that came out for those who stayed more than 7 days. So this is very telling in terms of the length of stay data, what's driving some of these individuals staying much longer. Now I'm going to switch to some of the barriers to food intake. And so we collected in this data collection, the patients completed a survey at the end of their discharge. About 90% of people completed this survey, and it was typically self-administered, though some also had the project coordinator administer it to them if they were frail. But here we have a sense of what are the challenges around food intake in the hospital setting. So I'll just walk you through a few of these. So, for example, we'll start on the left-hand side. Almost 70% of people, when they missed a meal, they were not given food to replace that meal. Okay? So if the menu's been hopefully planned to meet a third of the calories at each meal during the day, and they've missed that, that's a significant problem when you think about recovery. 30% had challenges with opening packages or unwrapping the food. And so we've got food access issues in the acute care environment when someone can't open the food that they have. Reaching the meals. The tray was on the other side of the room, at the end of the bed, not within reach of the patient. 1 in 5 this was happening for. 35% had to avoid tests or avoid food for tests, which is quite a large number of people. Disturbed at meals, almost 40%. and not wanting the food they ordered. So this is only for the subset of hospitals that actually had a menu select process. And so this shows us that often prescribed diets will remove foods that someone has selected on the diet, and that leads them perhaps to having dissatisfaction with that food that is provided. Being interrupted by staff, 42%. Poor position for eating, 27%, so trying to drink their tea laying in bed. And not getting help when they needed it. So this is only people that said, I needed help to eat and I didn't get it, 42%. That's a huge number when you think about the potential problems with older adults that are frail in the hospital setting. So we've got significant issues around food intake and what can potentially perpetuate that low food intake that we saw on that one slide for individuals that have malnutrition. So I want to show you here who are the people that are more likely to have these barriers. And so each of these sets of questions can be put into a scale. And we have on the top here the different scales that were part of this questionnaire. So there's a hunger scale, an eating difficulty scale, a food quality scale, an illness scale, and an organizational scale. And I just highlighted for you that the malnourished patients were more likely to have problems across all these areas, okay? So eating difficulty, they didn't like the food as much. Illness was likely to affect their food intake, and that was things like poor appetite, nausea, vomiting, things like that. And organizational barriers, and this is not being able to open the tray, for example, missing a meal because of tests and things like that, and not getting replaced. The other group that had many of these barriers was those consuming less than 50% of the food. So you can see they were having food quality issues, illness problems affecting their food intake, and organizational problems as well. So this is probably most telling as well around thinking about how we deal with this problem. And this is where our responses come in because of this data, saying that essentially when we look at who received a dietitian consult to address the concerns they were having around food intake, it's not necessarily the people we want to be getting that consult. So this data analysis was published last fall. And we identified that type of hospital, so an academic or community hospital, having a diet tech. So some provinces don't have dietitians and others do. And surgery do not influence whether or not you saw a dietitian in the hospital. And this was in a logistic regression. Only one of the 18 hospitals actually was here in Winnipeg that actually had a screening program, but it wasn't fully linked to the RD assessment process. RD saw 23% of the patients in our sample, and 45% of those patients were well nourished. They saw 36% of the people they saw had SGA-B or mild to malnutrition, and 19% of the patients they saw had SGA-C. When you flip that and say, okay, what malnourished patients, what proportion were actually seen by the dietitian? A referral process missed 3/4 the mildly to moderately malnourished patients and missed 60% of the severely malnourished patients. So however dietitians are being led to being consulted for a patient is missing the mark when thinking about malnutrition in this patient population. So let's look at actually what did drive that assessment. Oh, sorry, I didn't have that in that slide deck, sorry. I'll tell you right away, though, that the key drivers of an assessment by a dietitian were often the symptoms that occurred post-hospitalization, like constipation, dysphagia. And at admission, it was things like metabolic diagnoses and the diet you came in on. So it didn't have anything to do with your actual nutritional status based on SGA, which is unfortunate. So based on these data, so knowing the prevalence of malnutrition being 1 in 2 almost, demonstrating that low food intake is extremely common in this patient population, seeing that there's lots of barriers to that food intake that's occurring in these patients, and that we're not getting the right people to see that specialized service of the dietitian, we need to change what we're doing in terms of acute care practice. And that's the response by CMTF. And so we were fortunate to receive funding from the Technology Evaluation for Elderly Network last year to develop a nutrition care pathway. And I'll walk you through how we developed this pathway and what it looks like. So there are various pathways out there that have been developed in a variety of ways. Some are based on systematic reviews, some are based on expert opinion. Some, when you read over how they were developed, you're kind of wondering, how did you actually develop this thing? Because it's not really quite clear how the development process has been. And knowing what we knew, which was that there's not a lot of data supporting the process of care in acute care. We didn't want to solely base a pathway just on a systematic review because it would not be very fulsome, basically, in thinking about all the various issues. So to give you an example, if you were to do a systematic review to say, should we do body weights in patients in acute care, you won't find very much evidence about that. But it's an obvious thing we should be doing for patients to understand their basic needs, right? But if you look into the evidence and try to find evidence that says body weight's a useful thing to do in acute care, you won't find it. So there's the limits of doing systematic reviews to get guidelines and to develop things like a pathway. Rather, what we did was we started with an environmental scan of what other people had done, including those that had done really good research, as well as just frankly, strictly opinion about what should be done, and accumulated that together and put that into an evidence document that we provided to a group of stakeholders, and this was 30 stakeholders from across Canada. We brought, first off, a small group together to look at a draft algorithm to get a sense of were we on the right track, and we took that draft algorithm to this expert stakeholder meeting exactly a year ago today, actually, right? Is today the 30th or the 29th? 29th, yeah, year today, okay. And so we took this pathway, we knew it would be cut apart by the stakeholders, that's exactly what we wanted. And so we took a one-day process and walked through the pathway and said, what are your concerns about this? Where do we need to talk about this in more depth? What are the challenges with this pathway? And all of that talk and discussion led to the next step, which was a Delphi survey, which we conducted over the summer months. And we did 2 rounds of that. So that stakeholder meeting led us to the questions we actually put into a Delphi and a draft algorithm that we kept modifying through this process. And so we did 2 rounds of a Delphi, which is basically a way to get consensus quickly and anonymously, and a way to make sure that key opinion leaders don't have any greater voice than anybody else. So it really equates the process. And so we had 2 rounds, as I said, with 26 people completing both rounds, and it was, again, national. In addition to developing the pathway, we then decided we need to go beyond that. We need to actually do what we call face validation. We wanted to take it to 4 naive, let's call them that, clinical units who hadn't been necessarily part of the stakeholder process and say, here's this pathway. What do you think about this? And could you implement this? And is this the right thing to do? And across the board, they said, yes, it is the right thing to do. So this was allied health, not just nutrition people, to say, yes, this is what we should be doing. They said the challenge is in the implementation of this thing. And so that's where we are at now. In addition to that, we created a few support documents to support the actual rolling out of the INPAC. And those include a patient self-assessment of food intake. We call the PMIT, the patient meal intake tool, a discharge communication tool, as well as a mealtime audit tool. So this is the pathway. So I'll briefly walk you through this. It's called the Integrated Nutrition Pathway for Acute Care. And the reason why it's called integrated means it's not one single discipline. It's integrated into the care processes across the roles of various people in the unit, in the system. And you can see we've got a timeline on the left-hand side to give you a sense of when these things should be happening. So all this should be happening within the first day of admission. We have a Canadian Nutrition Screening Tool, which is these 2 questions that have been validated in reliability testing within the CMTF. We did 2 studies demonstrating that quality of the tool. If a person is at risk, they go into subjective global assessment. This is our recommendation. Those are identified to be SGA-C or severely malnourished, receive specialized nutrition care, which would be basically a full assessment by a dietitian, the individualized treatment that you would expect a dietitian provides. Based on our CMTF data, this is about 12% of patients. So that should not overload the system, right? SGA-B would go on to what we call advanced nutrition care. These are people that we don't necessarily go right to individualized prescription, but we know that they're significantly having some challenges around nutrition, and we can put some standard things in place. It might be more food on the tray, it might be in between mealtime nourishments, it might be a med pass with oral nutrition supplement. All of these things might be the things that we would do. It could be up to the unit, quite frankly, to figure out what are these advanced nutrition care practices. It's like a bundle that you put into place automatically for this patient to see if it can support food intake. Level A are those individuals who are not at risk originally or who are deemed SGA when you do the SGA assessment. And standard nutrition care is basically those things that everybody should have their tray opened if it needs to be opened. The tray is available to them. They're positioned properly for eating, etc. Everybody should get that standard of nutrition care. And you can see here that what we've used, rather than wait to get a sense of who should shift up in terms of going from level A to B or C, is food intake. We found in the CMTS study even a crude indication, so not a calorie count, a crude indication of yes or no, did the patient eat half of their tray, is sufficient to say this is on their way to recovery or not. And so a crude indication is quite fine. And one of the tools, as I said, we created in this TV and Callis grant was actually a patient self-assessment tool, which we validated against a dietitian doing the evaluation of the estimation of the tray. If a person is level B or C, they should get a discharge nutrition care pathway. So this is the pathway that was developed, and you're all saying, well, does it work? That's the next question. And so I'm not going to go through this in detail, so I just walked through some of the key things that we've done with this in the essence of time. I can come back to this. But this basically went through quite a bit of validation in terms of, as I say, the focus groups, but also the support documents went through a variety of validation that we've done with the mealtime audit tool and the meal intake tool. So they're ready to use. The next step, though, is does this work? So we're trying to change practice. But people will say, well, how much time does it take to do an SGA if we do this triaging? Or how much time is it going to take to do food intake monitoring? Or what proportion of patients can actually do that patient self-assessment? And what proportion does it need to be a healthcare aide or someone else doing that mealtime intake tool? And so we were fortunate enough to receive funding, again, from Technology Evaluation for the Elderly Network for a 2-year implementation study. And we're looking at 5 hospitals across 4 provinces. And the goal is, can we implement this? And how do we implement this? So we're not looking so much at the outcomes for the patients, but how does this thing roll out? And so we've chosen 5 hospitals that are very different to give us a sense of that. And so the outcome will be an impact implementation guide, how-tos, case studies, support materials, so that other hospitals can actually go forward and move ahead with this as well. So more to come on that, hopefully, in the next couple of years. So I'm going to turn it now over to Carlotta. And I have a feeling I went a little bit over time, and I did. And she's going to give us some examples of first off, frameworks around implementation science and examples of learnings from the Alberta Health Services and initiatives to improve food intake.
Thank you, Heather. We just click, right? Okay. All right, so that was kind of an introduction already. So yeah, my job, as Heather said, is to really share some of my practical experience in using an interprofessional approach to improving the oral intake of hospitalized patients. Oops. Okay, so what is the patient's experience at mealtime? As Heather demonstrated through the CMTF research, we know that there are numerous barriers to food intake while in hospital. So in identifying the opportunities or prioritizing what we want to look at for improvement, it's really important to understand the patient's experience. So first off, I just really want to emphasize that we do need to listen to our patients' stories and involve them in finding solutions. In implementing strategies to improve food intake, we know that the current behaviors and practices of our healthcare professionals do need to change. And we know that even when people value the change, I think it's really important to apply a guideline in practice. Change is really difficult in our hospital settings. So in order to support this, we are looking to behavior change theories and implementation science to help us understand what will make us more successful. So I'm going to share with you some of the examples that we've been applying in practice to learn about how we can more successfully implement changes within our practices. French and colleagues they completed a synthesis of over 80 behavior change theories, and they created 14 domains which can be used to understand behavior change. They call it the Theoretical Domains Framework, and it emphasizes the needs for clearly articulating roles, addressing barriers for individuals, for teams, and for the hospital systems, and for measuring and monitoring the change. And there's 4 questions that are important to think about. Who needs to do what differently? Like, for example, who will position the patient to be ready to eat, who helps the patient set up the tray, who assists the patient with eating. So all these questions really are articulating who needs to do what differently to be successful. Looking at what barriers and enablers need to be addressed. This might include time, resources, the skills needed to undertake what could be implemented, but it also includes what is the norm. Is it the norm in the healthcare, on the unit, for whoever sees someone who needs assistance to go and jump in it and help? Or is it the norm to say, well, that's not my job, that's their job, so I'm not going to jump in it and help? So it's really important to understand what are these behaviors that need to change, and what are those barriers and enablers? What are the interventions that can be used to overcome the barriers and enablers and facilitate that change? And then, really important, is how do we measure and understand the changes and sustain that? So these questions can really be helpful in planning the change that we want to undertake. But we know, like I said, changing practice is complex and difficult. So to create a more systematic process to implement change, Mitchie and colleagues developed the Behavior Change Wheel, which if you haven't seen it, she's recently published a book that walks through much more detail and has lots of worksheets and activities to support the model. It builds on the theoretical domains framework, and at the center of it is called COM-B, which is a well-established acronym for what will motivate behavior change. Includes capability, opportunity, and motivation as key drivers of behavior change. So at that center, the key is really understanding what are the behaviors and what's influencing the behaviors of our health professionals and how they can really work together to support the intake of patients. So starting with those behaviors, and then planning the interventions is the next more ready color that will link with helping us to address those behaviors. And then the outer row is different policy categories that can provide additional intervention support for the changes. So really emphasizing that starting to understand what is influencing the behaviors of our healthcare team is important in planning any intervention. In addition to some of these behavior change theories, there's also been a lot of research on how do we most successfully communicate the change. And so planning that communication in a very systematic, thoughtful way is really important. And one of the models that we've looked at is called the ProSci Change Management Model. It's been widely researched for many years and used in different settings. It includes 5 key building blocks to build: first, A, for awareness of the need for change; D, the desire to participate and support the change; K, for the knowledge on how to change; A, for ability to implement the required skills and behaviors; and R, for reinforcement to sustain the change. And so the model is called the ADKAR model for that acronym. So in essence, this model has tools and processes to help us plan communication to more successfully create the motivation and capability for our health professionals to change. Another model that I really like is called Frontline Ownership. And this has really resonated with our teams. We had Dr. Michael Gardam come speak at our Enhanced Recovery After Surgery Symposium, and he also spoke in Alberta at some patient safety sessions. And the teams really resonated the idea that the frontline teams need to take ownership over it. They need to be involved in the planning and create the solutions. So this has been a really helpful framework that we've really applied in thinking about how do we more involve the frontline teams in planning the changes versus having leadership articulate what they'd like to see be done differently. And this helps the teams become more motivated and together builds their capability to make the changes, and they strategize to address those barriers to change together. So what will achieve improved oral intake in hospital? It's a difficult question, and there's a lot more work that needs to happen to really understand what's going to make us more successful. We do need to have more research on the interventions to find out what works. We need our teams working together with patients to find solutions. But a key is that we do need to change the culture of teams and the value that they place on support for health outcomes. We need these teams working together. So I've just described a few examples of implementation science research frameworks which can be applied. And next I'll move into sharing some examples from our teams in Alberta Health Services in terms of how they're trying to address some of these food issues. So Heather showed more detail, some of the barriers, or what I'm calling food issues here, to addressing adequate intake in hospital. And you can see many of these are not something that one discipline can address alone. We need the nurses involved, the physicians, the dietitians, other allied health like PT and OT. Everyone needs to work together to help the patients optimize their intake within hospital. We recently did a survey of dietitians in Alberta Health Services, and we have about over 200 dietitians who received the survey working in inpatient areas, and almost half of them responded, and we gave them a case example of a patient who's malnourished, and we asked them, what kind of treatment would you recommend for this type of patient? And the majority of treatments were what we would expect, supplementation with an oral nutrition supplement, high protein, high calorie diet, or liberalizing the diet. I showed this slide because I just want to point out that these are strategies that are more diet-based or nutrition-focused, and that they aren't addressing the barriers to why the patient actually may not be consuming their tray at the mealtime. So what we really need to be looking at further is, and what are the interventions that dietitians can recommend that go beyond, that help the patients overcome those barriers. So last year in Alberta Health Services, we launched Enhancing the Patient Meal Experience, which has been, over the next few years, is being implemented across over 100 sites within Alberta. So you can see all the sites on our map here. And it involves more of a process around how we're trying to work with our teams and internally within patient food service to improve the patient meal experience, which will hopefully lead to optimizing intake. We're building awareness of this initiative through different communication methods, including presentations to site leadership, and as well, this is an example of an internal Alberta Health Services communication. We've created posters for posting on the patient care units, and as well, there's a little more detailed poster that's put in food service areas in the kitchen, for example, to highlight a little bit more detail for the food service workers about what enhancing the patient meal experience means. We have strong leadership support. Leadership support is really essential to help move any initiative like this forward. And I'll just read the quote from our leader, Susan McKay, who's the Senior Operating Officer for Nutrition Food Services. She states, "We are starting the conversation with others about how we can work together to improve the patient and resident meal experience. Using appreciative inquiry, teams can build on what's going well, dream about an ideal state, and collectively decide how to get there. Together, I think we can assure we are putting patients first at mealtime." So I thought that's a really good example of how our leader of patient food service, so we have the leadership there to help drive some of these changes forward. So we're very fortunate in that way. Enhancing the patient meal experience includes a focus on food choice. So this is an example where in patient food service, they've been trying to shift where they've had some non-selective menus where patients don't choose to more selective menus. So this has been a lot of work for our sites that have been previously non-selective. There's work that's focused on food quality. This is an example of looking at how can we plate the trays better for those patients on puree diets, and through culinary training, they've made lots of improvements to the appearance of the puree tray, and hopefully that will make it more appetizing for patients to eat. And as well, there's been a focus on customer service. An example was last year, training days for all the food service workers, looking at how we can improve. So these are what reflect on internal activities in food services to improve food quality, food choice, and customer service. But we know we can't do this alone. So that's led to our appreciative inquiry tool, where we've been engaging health professional teams by doing presentations, encouraging the use of this tool, where the teams identify where they fit. So on the right-hand column are the best practices related to environment, timing of meals, protected meal times, customer service choice, food presentation and appearance, food quality, menu selections, and point of service support. So on these dimensions, they rate where they think they might be on a scale of 1 to 10, and then identify some of the greatest strengths and areas for improvement. And using this kind of tool with the whole team and having that dialogue can help them maybe identify some areas that they want to focus on. So I'll share some examples in a moment of how this has been applied. Sharing examples from Edmonton, Alberta. I'm from Edmonton. It's from Calgary, Alberta, Peter Lougheed Centre and South Health Campus. So an example from PLC is the team got together and used the appreciative inquiry tool, identified some areas for improvement in customer service and point of service support, and they ended up working with volunteer services to look at how they could have volunteers open packages and socialize with patients. The socializing with patients an added benefit in terms of improving intake as well, because that can be beneficial. And then another example is the food service manager at South Campus, who's very passionate about how we can make a difference, she had a meeting with the infection control nurse and the unit manager and another nurse to talk about the tray delivery and hand hygiene. So it wasn't related to malnutrition or anything like that, but the conversation somehow led to the issue that there isn't enough time to set up the trays for the patients. And they found that one unit only had 45 minutes to set up the patients for their breakfast tray, and that the next unit on the other side had an hour and a half. So in understanding that this issue had never been brought up, no one raised it, said, how can we change that? But through these conversations and thinking about how we can do things better, it brought up, well, we could just shift meal times for this one unit, so the one unit has more time to set up the tray. And then it led to more discussion about tray delivery guidelines and the roles and expectations for the nurses. They started to do a process where they swept the unit before the food service would deliver the trays. The food service worker would announce that the trays are going to be delivered, so everyone knew that this is the time to go do that sweep to make sure that the patients were properly positioned, that their trays were cleared. In the past, there might have been stuff all over their tray, or there might have been even a urine bottle there. That's something you didn't want when you're eating. So getting the patients set up and having the tray delivery ready was really important. Another example with this food service manager is they did a presentation for the enhanced patient meal experience to site leadership. And diagnostic imaging was at that presentation and said, oh, we'd like to learn more about this. And they asked the nutrition service manager and food service manager to do a presentation for their team. And that led to more discussions about, they didn't even realize that taking patients to DI during mealtime was an issue. But they could fix that. Then they realized they could change the schedule so that DI was doing more outpatients during mealtime, and then they could do the inpatients at non-meal times. So just raising these questions and having these discussions has created an awareness, is helping the teams to change and make these small changes, but they all add up to make a difference. Another example from the Peter Lougheed Center has been that they've been meeting throughout this past year to look at how they can incorporate nutrition risk screening and then also have appropriate interventions to address. So this was before the pathway that impact has been available to us. So this team realized that they wanted to be able to do a better job of addressing those patients who are identified at nutrition risk. So they met regularly together. They did a good current state assessment of what the opportunities might be, identified what things that they could agree to change, and they implemented this past April. So we'll have to see how this goes, and there's a whole evaluation plan being undertaken. But it's been a really good example of how bringing together an interdisciplinary team for that site and also having some provincial supports has been really beneficial in moving forward with some change. Next, I'm going to share with you some examples that we have related to our implementation of enhanced recovery after surgery, or ERAS, as we call it. And there's a presentation tomorrow more about rehabilitation related to ERAS. But since 2013, we have been implementing enhanced recovery after surgery at 2 of our sites. And this is an example of one of our teams from PLC, who've been working together to implement these 22 best practice elements that relate to before surgery, pre-surgery, intraoperatively, and postoperatively. So it's a huge undertaking to look at how do you make sure you're applying these 22 best practice standards. And they include two nutrition ones related to intake, include identification of malnutrition preoperatively, and then the postoperative nutrition supplementation. And we have been applying the IHI collaborative model, which you can see here. If more information in the Breakthrough series, IHI's collaborative model for achieving breakthrough improvement. So the different teams that are implementing together can learn from each other and do plan, do study, act cycles or PDSA cycles to implement changes. And here's a picture from our first collaborative meeting, or Train the Trainer meeting in June of 2013. So the example I want to share is from our Grey Nuns Community Hospital. And so part of the learning collaborative process is to have a scorecard that indicates targets that you want to achieve, and the teams work together on deciding what are the measures or what are the issues that they want to work on. And this team, one of the first things they came up with is that they need to improve the nutrition supplementation after surgery. And so it was really exciting for me to be involved in hearing nurses and non-dietitians strategizing how are they going to do this. So they had lots of discussion about how they could improve the nutrition supplementation after surgery. They created their action plan, and this was really using a frontline leadership approach where the nurses were really actively involved in identifying those proposed actions. We did have some nutrition guidelines provincially on how we were recommending the postoperative supplementation, and it included a MedPass program that to meet the 600 calories that ERAS is recommending after surgery, they were using 60 mils of 2-cal 5 times a day. And so the team worked together and realized for that site, that wasn't working ideal. They wanted to try fewer times a day with a larger volume. They thought that maybe Ensure Plus would taste better than 2-cal, so they tried Ensure Plus. So the frontline team had these ideas that were different than the provincial model, but that's okay because by having them identify what they wanted to do, it got them more invested and more motivated. So even if Ensure Plus versus 2-cal probably doesn't make a difference. But by having the teams come up with those solutions, they're more excited about it and more willing to go forward. We had a provincial logbook, and they created their site logbook that the patients filled out that, again, aligned with their education and their whole program. So they've really shown success in improving the compliance with the postoperative nutrition supplementation by taking this team approach and implementing these strategies. So in terms of some take-home messages, in summary, I do believe that the healthcare teams can make a difference with small incremental changes. To build motivation, capability, and opportunity for change, frontline ownership is essential. And data is really critical to monitor the change. Data is some of the hardest thing that we struggle with getting, but we do really need some good data to evaluate whether we're making a difference. In addition to the frontline ownership, we need leadership to help us remove those barriers, communicate results, and they can also really support spreading successes to other patient care areas and other sites. So how do we get started? To get started, one of the first things to do is really identify your team. Include physicians. Physicians are important leaders to have on the team. Include some of those informal leaders, like for example, if there's a nurse who others look to, or maybe that senior nurse, include those type of individuals. But having a really good multidisciplinary team is really key. It's important to create awareness of the issue and the importance of malnutrition and addressing poor food intake in hospital. And look for opportunities within your hospital, for example, if there's a quality council or some sort of opportunity to raise those issues where you can. It's really important to emphasize that everyone has a role, that every member of the healthcare team and the patients as well and their family all have a role and can have an impact by working together. We need to identify specific targets and actions and start small and monitor success. And where appropriate, policy and protocols can be important to sustain change, and this might even be changing order sets or things like that so that the change becomes part of standard practice. For the teams going forward, did you want to speak more about this? Okay. I know, I'll let you come up in a moment. But I was going to say, Heather's going to just share a little bit more about the resources that are available for the teams going forward. I think it's really important to find what resources are out there and use them to help be successful. And as well, just one thing before I give it to Heather, I just wanted to give a last plug for, I really think that researchers, because I know there's some researchers in this conference, and the healthcare professionals need to work together on evaluating the interventions, because there's such a gap in the literature on what's successful for addressing hospitalized malnutrition and how to promote intake. So we need to work together to have some more good guidelines out there, more evidence to inform practice.
Thanks very much, Carlotta. And don't go too far away. We'll have lots of discussion, I hope. So I just wanted to remind the group, because the research at CMTF has led to actually resources that can help practice. And so that's kind of the interesting thing about doing the applied work that we've done is First, we have the impact, that is a guideline, in essence, or a pathway that can be followed, and is a resource that people can use. And we consider it a minimum standard. So certainly hospice can go beyond that and do a better job beyond what we suggest. We have the Canadian Nutrition Screening Tool, and there's other valid tools out there, but this one is valid and reliable and also very easy to use. And so if you look at some of the other screening tools, you might see that actually the validation might not have been realistic in terms of what is happening in your setting. In addition to those tools, we've actually worked hard at CMTF to also think about creating tools that help to roll out change. And so one is the SGA. We haven't revised SGA. We've actually taken a look at the form that was originally used, and then also subsequent generations of the form, and realized that there's some misconceptions about the SGA because of the way that form has been laid out. And so we worked hard over the last year to revise that, and you'll be seeing a new form as well available for people to use. The patient mealtime intake tool, as I talked about, has been validated in the first TVN Callis grant. That's going to be available on our website soon as well, to support people looking at how can we audit or look at food intake without doing calorie counts. So something very brief and simple that can be used. Mealtime audit tool, the same thing. If you look in the literature, we don't know much about barriers because no one's been measuring them. And so rather than just creating a research tool, we actually created a tool that people could use in practice. So food service managers, for example, or others on the unit might decide to say, let's do mealtime audits on a routine basis and watch how our barriers change because we've actually done some intervention work. Patient access and satisfaction question that we used again for the CMT research is now on our website to use as a piece to get a sense of satisfaction from the patient's point of view. Again, something that can actually help you to shift the awareness in your setting. So demonstrate to people that, yeah, hey, we do have a challenge here. We need to move forward. And the same thing with a physician-nurse survey. So all the tools that we actually use for research can now be used in practice to help change the culture of care as well. And so those are all readily available on the CMTF website. Well, they will be very soon. Yeah, very soon, hopefully. Yeah. So we're going to open it now up for discussion with the group. We've got a good 15 minutes or so for discussion, which was what we wanted to make sure we had time for. Questions around changing in process and things like that. And I have one question for Carlotta now. If there's one thing to do, if you're not doing anything right now, what would it be, based on your experience with ERAS and with the 100 sites trying to move forward in terms of improving the mealtime experience? What would be the first thing you would do?
That's a hard question.
I know.
Well, in going back to that ProSci model that I shared, I think the first thing we need to do is create more awareness of the problem, because I think that in our hospital settings, there just is not the awareness of malnutrition and the issues associated with poor food intake in hospital. And I think back to one of our nurses for enhanced recapture surgery. She shared that before she was involved in that project, she really didn't understand the extent that the issue of malnutrition was having for that patient population. And then she ended up being part of that Delphi process. But it was, and I think that's why, because we realized, oh, she'd be a great nurse for that, because we've kind of converted her on to that. But creating that awareness and understanding of the importance, I think, is a good place to start.
Well, and hearing you say that the diagnostic imaging had no idea that it was a problem. And so, you know, many hospitals might not have a full suite of people that can do those presentations. So perhaps even the very first thing is figuring out how to work the time of the dietitian to carve out a position for like 6 months to say, we're going to slam this issue in this hospital and see what shifts we can make, because you need to have that time and space to do that. And some of the CMTF resources will be available to help you with that in terms of slide decks and things like that very soon. So getting the message across to your hospital that this is the issue in Canada, what can we do about it? Yeah.
Yeah, and with our Enhanced Patient Meal Experience initiative, we've been creating standard slide decks just like that, and the food service managers and the nutrition service managers are the key individuals going out and doing the presentations for the site leadership, and even Susan McKay, our leader, was going to zone leadership. So at different levels, depending on who your target is, but engaging and having tools so that we can more easily facilitate people to use those tools and present, I think is important. The other thing for the discussion, I'd be interested in hearing, I know there's lots of experience in this room, other examples that you've had from your hospitals and facilities on how you've addressed this issue.
Hi, I'm Brenda Hodson. I'll speak on behalf of the Winnipeg Regional Health Authority and dietitians and interdisciplinary group. So what we did is Donald and myself did a roadshow, and we did presentations to a variety of groups in leadership positions, including our senior executive within our region. And we also, with regards to the Canadian Malnutrition Task Force results, and we also brought local data with regards to what our intake information was for med-surg patients and some anecdotal stories about, we had a family member who had written us an email and the subject of that email was starving to death and wanted to know if it was our hospital policy to starve people to death. And we also had a situation where an individual had written a letter to our hospital just giving kudos to a dietitian who went out of their way to actually open his packages of food. And he was in hospital because he had a workplace injury and had cut off his fingers. So the fact that only one individual in the entire unit helped him was quite an eye-opener. So bringing that anecdotal information too, and it resonated with people, and even several months later, we still get people coming up to us and they remember it. Mm-hmm. So as a result of that, we were able to create a regional malnutrition steering committee, which is an interprofessional group. And I think awareness is huge. Mm-hmm. And just getting different disciplines to identify what is their role with malnutrition, what can their discipline actually do to address it. We're starting people to have those discussions. To increase awareness, we've also worked on diagnosing malnutrition. So we've looked at chart audits and what's the rate of diagnosis of malnutrition. If 45% of patients are admitted with malnutrition, do we call it malnutrition? And we discovered, depending on our site, it varies from 0 to 31% of malnourished patients are actually diagnosed with malnutrition. So no wonder the healthcare team doesn't know patients are malnourished. Nobody's even mentioning it in the chart. What about physicians? Well, they diagnosed it about 3% of the time. We looked at CIHI data as on admission and found out that the ICD-10 codes, and it is 0.19% of malnourished patients are actually mentioned that they're malnourished in the chart. So I think that's a huge piece. We need to do awareness. We've done MedPass trials within pilots within certain sites, and we found that we actually had an 8% weight gain in MedPass, very positive. So we're working on a regional strategy to implement that in all our sites. And I could go on. We've been screening since the late 90s, so we have a lot of nutrition screening experience, and we need to still tweak that and make it better. But I'll let other people talk.
That's excellent, Brenda. Thanks very much. Other folks in the audience? Any experience with trying to make changes right behind? Yeah.
It's mostly regarding policy making that I have a question, because Alberta Health Services is one health services. So there's no regional health services or anything like that. It's just one thing. Mm-hmm. In Ontario, it's LINS, so Local Integrated Health Networks. So that being said, all hospital has their boards, their CEOs. So how would you be able to implement a program like that when every hospital has so much power?
Yeah. Do you have a comment, Carlotta?
Actually, I'm not really big on policy as a key driver for change, because policy in itself puts it on paper saying what you want to achieve. But then behind that, you still need to do all the work to create that change and change behaviors on the unit. And so having the piece of paper, to me, having a policy doesn't always change, but it's helpful. If you're dealing with, and even when we have Alberta Health Services as one organization, creating a provincial policy can be quite difficult. So working through your local hospital and local policies, I think can be as effective as we would be in having a provincial policy, because it's just where you want a vision of where you want to go, and behind that, that's where you're going to be doing all the work really to make the change happen. Does that make sense?
So it would be more like individual hospitals that would have to take the initiative.
I think so, because it's still the individual hospitals are the ones that need to have the buy-in that this change is important and they're going to support it.
Is it the hospital or is it the unit?
Or the unit even. Yeah, the unit. There you go. Thanks, Leah. It's at the ground level with the local teams in that unit that's going to make a difference. And starting with each individual people on that unit, like the nurses and the individuals on that unit, I think ground up, we create change.
If I can just add to that.
Yeah.
So outside of the screening piece, there actually has been pretty good research around protected mealtimes in the UK, and they did put policy in place and showed it failed. So without digging the policy into the practice, it's never going to work. And so you really need both approaches. And so I think what Carlotta is saying, starting with grassroots gets the fire going, and then the LHINs can't ignore it, right? And so that's what might be happening. Bridget, you might have some comments too from
Yeah,
Ontario.
I was just going to add that Heather and I are both from Ontario, and there actually are several hospitals in Ontario that have really taken this on as a cause. I work with a CMTF, so I'm aware of it. We're trying to get them to post their stories on our website, and it can be either at the unit level or driven by, in many cases, an individual champion. And the hospitals so far that are starting to implement a fair bit of change tend to be driven by dietitian champions. But they just need to be tenacious and get more people on board, which would include physicians and nurses, just like Heather presented and Carlotta presented. So we are making changes in Ontario. Unfortunately, we don't have the big one omnibus region to work with, but it's starting to infiltrate, which is very exciting.
So, if your hospital isn't doing any screening, for example, even getting in front of the physicians, like we can always come out and do a presentation first off, so the awareness, if taking off your shoulders. But if you do want to do the awareness piece, there's e-bulletins from CMTF and our papers you can access, and hopefully very soon some of our slides as well. But in addition, start with screening on one unit and show them in 1 week, this is the prevalence of malnutrition, and how many people actually saw the dietitian that were malnourished. Just a really little study like that, and the tools are there to do it, right? Or to do the mealtime barriers and say, we're going to take one meal on this unit and show you how many barriers there are to food intake. And so starting with those little bits of local data, as Brenda said, is really important. And the anecdotes from patients, when you're doing that data collection, when you're asking them about nutrition risk, and they say, you can ask them other things as well. Those little bits of information really resonate within the individual hospital.
I just wanted to also add a comment that dietitians in Canada have a clinical nutrition managers network, and last Friday they had a teleconference annual general meeting, and the main thing on the agenda was malnutrition. And I did want to thank everyone in this room that's been involved with CMTF, because I think that definitely has been a catalyst to have people look at an age-old problem within our hospitals, right? So every province reported on what they're doing since those results have come out, and it was amazing to hear all these different places and provinces and sites that have started nutrition screening here. I think everyone had reported on nutrition screening, trying protected meal times in different units, doing a variety of different things. So there's a lot of activity across our country since CMTF. So I want to tell the group that and thank them.
Thank you. Other points and comments from folks? I think the key is to start, right? And to start small and just start the conversation. Yeah. Anybody else? Well, if I can just end with thanking first off Carlotta as well as the audience for their participation today. And this conversation is ongoing. So CMTF is for you. And so if you need something that we can do that can actually help you change what's going on in your hospital, we want to hear from you. And so Bridget is our executive director, and so emailing her. And we have gotten all of our insights about how to change culture from grassroots. And so that's why we've gotten to the place we've gotten to today, because of you and that feedback about what you needed. And we can deliver some of those things to you and help you move through that process. So thank you very much.